Hello everyone. Hi. Good evening. Voice is good. All right. Welcome everyone to day 4. We'll have a last session of dermatology. Everybody settle down. No audio. Anurima, please check. Please check now. I think the audio should be okay. Everybody should be getting audio. Yeah, it's okay. Yeah, fine. All right. Nice. Hi, good evening. Hello. Sunshine. How cool is that? Okay, hi Rashmi. Neha. Nice. Satish, hi. So nice to hear you as well. Honestly, it's always a genuine pleasure when we get to connect like this. Seriously. Right. Everyone. Let's get the last session in. Everyone. Right. Okay. Right. So everyone in place. All right. Right. So let's begin. Let's begin the last session. Okay. Jay, you don't have to write this. Okay. I'll tell you why we don't want you to write this, because the video will be available for you to check on later. So you'll anyway have the resource, right? So don't worry about writing stuff. The reason why we don't want you to write is almost all the slides are anyway labeled. So that should not be a concern again. Again, you see the video, so you'll have a revision there. When you tend to write, unfortunately, you also tend to miss something that we are saying. So concentrate on the vision part, concentrate on the audio part. Okay, there's no need to really write down something, write down, don't do that. That's going to be a distraction for all of you, right? All right. Okay. Right. Excellent. Right. Okay, everyone. Right. So let's begin this session, and let's begin this session with a broad, happy smile. Okay. Genuinely. Okay. The smile is, why we have this happy smile, right? The happy smile is that we are almost at the end of our race, right? And the happy smile is just to look back and say, oh, I've come so far. Don't look ahead. When you look ahead, you get stress. Ki future mein kya hoga? Oh, what is going to happen, in the exam and all that stuff. Look behind. Look behind and say, oh, that's a big journey I've already traveled. Okay. So pat yourself on the back. Have a happy smile to what you have already done. Okay. Don't lose focus of that. You already have a lot of work in place. It's just the finishing touch that all of us are wanting to give you. And please look back. Were you here? Were you at this brilliant position when you started with DAMS a long time back? You were so naive. You were almost not knowing anything. We have brought you to a stage where you can actually dream. Okay. So I want you not to look ahead, because when you look ahead, you're going to get a lot of stress in place. I don't want you to do that. Start with a very beautiful, happy internal smile, which says, okay, I've come very far. So let's begin with that nice positive thought that we have already come very far, right? Okay. All right. Now, what are we going to do today? Now, my intention today is only to build your confidence. That's the first buzzword I want you to understand. This session is going to be a confidence boosting session. I don't want to teach you anything new. This is not a new teaching session. It's going to be what we also call as consolidation of what you already know. Okay, what you know, I want to cement it, solidify it, so you don't really make a mistake in what you already know. Okay, there is nothing new I want to say. So what you will see today is, you will say, अरे sir, ये तो आपने पढ़ाया हुआ है, ये तो हमें आता है, आने से कुछ नहीं होता. Problem is consolidation is not there. So in the end, the final touch is not new information. Final touch is the cherry on the cake. We have done the cake already. We already baked the cake. Just want to put the cherry there, right? So today is a cherry session, right? It's going to make everything sweeter and nicer to look at. So that is how we look at today's session. Nothing new for you. Just going to play with what you already know. And let's begin this confidence boosting session. Let's, everybody got this? Right? Everybody understood what you want to do? Right. So what have I done? I've got about 30 to 40 minutes. That's how I'm going to do this. Okay. Right. Yes, you I know MBBS tends to be a joke, right? I know what you're saying. MBBS is a joke, unfortunately, where you'll say, yaar, ye ho bhi gaya, MBBS itna sa hi tha. In a sense, DAMS is your full 5 year, full MBBS curriculum, right? So what happens in that 1 year of DAMS is you actually become a doctor during DAMS, that's what we really look at. Anyway, so we are going to have 30 to 40 minutes. Okay, I'm going to do 3 topics, right? Again, everything is going to be done with a happy mind, all right? No stress in this session, nothing. You just feel joyful that, okay, we are just going to solidify अपने को आता है, कुछ stress नहीं करना है, कुछ लिखना नहीं है, just hear and see, right? 3 topics. What are the 3 topics I want you to see, right? Okay, now these are the short topics I feel is something is definitely going to be out of this. Okay, what do you mean? Pigment disorders, Hansen and blister. If I want to put my money on what's going to be there in the NEET exam, we will have these 3. Okay, and an outside shot of STD and an outside shot of alopecia. My understanding of what's going to be is this is going to be important, but these 3 are going to be the double stars, right? So this is why we need to have 3 topics in place. The STD and the alopecia, I want all of you to go to the DVT 2020 session that I did. Both of these STD and alopecia flowcharts and algorithms are there in that. I will not cover it now because I've already done it. And the pigment and the Hansen and the blister is what we are going to completely knock today, right? So let's start with this. Okay, everybody, let's start with what we will have here. Okay, I'll just zoom out a little bit so you can see the full slide. All right. Okay, now the first thing, we're going to start with pigment disorders. That's the first thing I want to do, pigment disorders, right? Okay, now please focus on what we are doing here. Everyone, please focus on this. Any question, and this is again an important question, I think it's going to be a relevant question this time. Any question of something white coming since birth, white since birth, we call it congenital white patches. Sorry, it's moved a bit. Congenital white patches. Okay, congenital white patches. Now, what do you mean by the congenital white patches? Let's talk about that. Okay, now let me just 1 second, give me a moment on this. Yeah, congenital white patches, right? Okay, let me just zoom this so that you can see what are the choices that I want you to get. Okay, the choices will be okay, albinism is one possibility. How will you diagnose albinism? Remember, it's going to be white skin and white hair. Remember these pointer words. I'm going to give you a lot of pointer words. White skin, white hair since birth. Remember, white skin, white hair since birth with white iris. Non-pigmented iris is very typically what we want to see, right? It's going to be diffuse, white skin, white hairs and eyes involved. It's also going to have tyrosinase abnormality, we know that, and normal melanocytes and absent melanin. Normal melanocytes and there's a problem with you seeing those slides. There's a bit of cutting, I feel. Okay. What I'll do then is I'll just make it full screen. Let's make it full screen. Everyone, let's make it full screen. Okay. The first one is albinism. Albinism is, I said what? Diffuse white skin, white hair, white eyes, tyrosine inhibition, and normal melanocytes but absent melanin. Right? Got this? Second one, piebaldism. This is a new topic I'm doing. Piebaldism is what? The neural crest itself is not functioning. So the melanocytes are not coming only. When the melanocytes are not coming, what will happen? The melanocytes are not coming, so melanin is also not coming. I'm adjusting the zooming out. I understand there is some zoom issue. I'm trying to work on it. Okay, okay. I know there's a bit of cutting. I made it full screen. See if that is okay now for you, all of you. Piebaldism, melanocytes are absent, melanin is absent. It's always going to be a localized disease. Remember, it's a localized disease process. Okay, so not a diffuse patch like albinism, just a localized patch. Typically piebaldism, always images will have white patch on the forehead. Remember this image, white patch on the forehead with a bit of white hair on the top, and that's typically how we look at white forelock. There's a term, remember this, white forelock. Forelock means front. white forelock. Okay, white forelock very typically, and that is what I want you to look at. I'll just change the settings a bit, so that again should not be a problem. Just give me a moment. I'll just do that as well. Okay, now I hope this will now be more easily visible to you. Okay, so now white forelock, forehead white patch, a bit of white hair. I'll show you all these images also. That's called piebaldism, neural crest defect. Third one is nevus depigmentosus. Remember, nevus depigmentosus is not depigmented, it's hypopigmented. That is what I've written. You'll get this PDF, you'll get the video. Don't worry about the what is written. You'll get access to all of this very soon. Don't worry about it. Just listen to me. Just listen to what I'm saying and hear me, okay? And see the images when I'm going to show you, right? Nevus depigmentosus is a hypopigmented patch. Hypopigmented patch, okay? Localized again, hypopigmented, okay? Here the melanocytes are there, but lesser. Listen on this, lesser melanocytes. See this, albinism, melanocytes present, melanin absent. Piebaldism, melanocytes itself are absent, so obviously melanin is absent. In nevus depigmentosus, the melanocytes are reduced, and that's why there's hypopigmentation. I'll show you the image also. Again, a localized but hypopigmentation. The last one, nevus anemicus. Okay, nevus anemicus. Okay, is again localized. Remember, it's not a melanin disease. Remember, anemicus meaning something to do with blood vessels. It's a vasoconstriction in an area, and that's why this becomes hypopigmented. So remember, albinism and piebaldism depigmented. Nevus depigmentosus, nevus anemicus hypopigmented, nevus anemicus depigmentosus localized, piebaldism localized, albinism diffuse. Did you get that? Did you get that? Indira Gandhi, correct, Indira Gandhi, right? Okay, see albinism, quick images now. Albinism you can make out depigmented iris, depigmented hair, depigmented skin. This is very typically albinism. Indira Gandhi had piebaldism. Indira Gandhi, you remember that white thing that she had? I'm going to show you the image. See this, can you see this white? Localized depigmented white patch on the forehead. Very typical image of piebaldism. Important question this year. White forelock. Fore means front, lock means hair, lock of hair, right? That's an English phrase. White forelock, and very typically piebaldism is how, that is how we are really going to look at it. Got this? Don't take notes. Don't take notes. You're going to get this. Don't take notes. Don't take notes, please. Okay, nothing to worry about this. Nevus acromicus. Now, can you see this? Can you see all of this? Are the images clear? Are you able to connect with what I'm going to tell you now, right? Nevus acromicus, also called as nevus depigmentosus. Can you see the hypopigmentation here, bache? Can you see it's localized but not depigmented? Compare this with the image here. Can you see this is depigmented localized? This is hypopigmented localized. See the difference? Got this? This is nevus depigmentosus or nevus acromicus. Got this? Now, how do you differentiate and confirm a diagnosis of nevus acromicus? There is something called as diascopy. You press with a glass slide. When you press with a glass slide, what is going to happen? What's going to happen? See this now. Let me just go ahead. Yeah. And let me just zoom in and look at the yellow arrow. This is the original nevus acromicus. Look at the right side. If you press with a glass slide, can you see the shape of the lesion remains the same? The shape was like this. The shape remains like this when you press with the glass slide. So when you press with a glass slide, if the shape does not change, so diascopy does not change the shape, that is typically the diagnostic point for nevus depigmentosus or nevus acromicus. In contrast, nevus anemicus is also going to be hypopigmented localized, so very easily confused with nevus acromicus. Difference is there is no increase on diascopy. Okay, meaning there is an increase. There is an increase on diascopy, meaning the lesion increases when you press with the glass slide. So nevus acromicus, when you press with the glass slide, the lesion remains the same. In nevus anemicus, which is a blood vessel issue, which is a vascular issue, when you press, the vascular issue temporarily increases when you press with the glass slide. So we'll say increase on diascopy with nevus anemicus and no increase on diascopy nevus depigment. Everyone, you got this? Okay? And that is how you differentiate the congenital white patches. Everybody got this? Are you able to read? Is the font okay? Is the font okay? Just check all that. All right? Okay. Now, if you have any question now on acquired white patches, remember we have done the congenital white patches, two depigmented and two hypopigmented, right? Now we do acquired white patches. Every time you always start by deciding in your mind, is it hypo or is it D? That's the first thing I want you to know. Depigmented hai ki, and how do you know depigmented? Remember the term milky white. If the image is showing a white as milk, it is depigmented. Anything which is lesser than milk color wise is going to be hypopigmented. Got this? Everybody got this? Right? Now, let's say what are the differentials of a hypopigmented acquired white patch. And the history would be the lesion is there since 1 year, since 2. That's how the history would be for an acquired white patch. Got this? Now, what are the terms for that? In any hypopigmented lesion, the first and the commonest differential is pityriasis versicolor. Okay, and just let's read this. These are all pointer words. Okay, perifollicular means around the hair follicle. Remember these pointer words. See, in an exam, you're already stressed. Okay, and it's too many things whirling on in your mind, right? You're thinking of 100 things. Stress is 90% of that thought process. So it's very important to pick up these pointer words. And you might say, "Yaar, sir, ये तो आप पढ़ा चुके हो, ये तो हमें आता है." I know that you know. But the problem is still you make errors in the exam because the common errors happen in what you already know. And that is where the rank slips. You don't want to do that, right? So remember these 4 words for every versicolor question ever that you will get in any exam, including NEET. Perifollicular, fine scaling, chest, back, face, and stretch sign positive. 4 ही है, कितना simple हो गया. So rather than having all the theory and everything of versicolor, 4 words. And remember, most questions in dermatology are going to be questions on diagnosis, not too many questions on treatment. So only focus on how to diagnose rather than anything else. Got this? Okay. Second possibility is Hansen. Okay, I'm trying to zoom in so that you can see clearly. Hansen. Remember, there's going to be sensory loss, sweating loss, and atrophy. For me, is a very important clue to Hansen in any question. Okay, so any question which says atrophic hypopigmented lesion, mark it as Hansen. Mark it as Hansen. Very important pointer words coming up. Okay. No scaling. Now this is always defined by scaling and this is never scaling. So again, these are very small, simple things. And usually you will have some endemic states mentioned. Thickened nerves, if it's given, then it's a giveaway. So the question becomes a simple question, but I expect sometimes the nerve history not to be given because otherwise it becomes a very easy question. So scaling being absent, atrophy is more likely to be a clue for the disease process. Okay. One more, PKDL, post Kala-Azar dermal leishmaniasis, third differential. Okay. Again, see, no sensory loss. Okay. No atrophy. Can you see this? There is no atrophy here. And there's fever in the past. We have done this in MCQs many times, and endemic remains the same and no thickened nerves. We know PKDL versus Hansen differential. We have done this so many times, but it's a good opportunity to consolidate what you already know. So can you get this trend of the theme of what we want to do? We want to consolidate what you already know. Okay. And the last one is pityriasis alba. Now pityriasis alba is no sensory loss, no atrophy, and it is a child, fine scaling, and a face. Remember the word pityriasis itself as a way to remember the scaling part. Got this? Everybody got this? And that's the 4 differentials of any hypopigmented. There's no fifth on this. It's just 4 classical diseases with acquired white patch. Everybody got this? Okay. Let me just quickly show you images now. Okay. Pityriasis versicolor, can you see the perifollicular prominence? If you have an image like this, where is the problem? So easy to diagnose. Okay. Again, so many perifollicular hypopigmented patches, chote, very small hypopigmented patches. Can you see the area is the back now? Back now, hypopigmented here, hypo here. And when you scratch it, you're going to get scales. Okay. Compare that to Hansen. Now, Hansen is also hypopigmented. Okay. There's no scaling. Okay. And sensory loss becomes something very, very important. Now there are 2 patches, one here and one here. This is classically, we are going to do that later also, which is BT Hansen. Sensory loss is a very important part of the equation. And see, very importantly, can you see the number of patches? So very importantly for versicolor, this is a very important pointer word. And there are so many questions which can just be solved by the word multiple. If you have multiple small patches, see the word now, multiple small is your pointer word. Multiple small is always versicolor. Okay, got what I'm saying? Multiple small is always versicolor. And can you see BT answer is not going to be multiple small? This is a very large lesion. Okay, so we'll say few and large. Got this? See the difference? Few large hypopigmented is Hansen. Multiple small hypopigmented is versicolor. So where is the confusion again? So just keep on focusing. If you want, you can just jot down these pointer words rather than jotting down the full notes. Just for recollection, you can jot down these pointer words. I also call them magic words or pickup words or whatever you might call it. These are more important than any mnemonics that you will create. Okay, because mnemonics को याद करने के लिए भी mnemonics बनाना पड़ता है. So that doesn't help, right? Okay. Now see the difference between PKDL and Hansen's. We have shown you this slide before. Both look the same. The difference typically is going to be, I have written that so that you get this later on. I've already labeled the slides. Okay, the difference is going to be in BL Hansen, some sensory loss, some nerve thickening and no scale, whereas this is going to have fever in the past. PKDL always has fever in the past, which is then suggestive of past Kala Azar. Otherwise, images have no difference between them. So you have to look at the stem of the question, look at suggestions as what it is pointing to. Accordingly, you go there. Got this? Okay. Now, I have specifically created hypo on the face separately. Okay, so I've separately made a chart on how to differentiate hypo on the face. So that I will tell you here. Up till now what we did, acquired white patches, hypopigmented on the body. That's what we were trying to do. Now we're just going to do face, because face I feel is independently important, and that is why I put it in a new topic, right? See the difference between indeterminate Hansen and Petrus alba on the face, right? Indeterminate Hansen and alba look the same, no difference between them. So what is going to be there now? Child becomes a very important part. Both are there in children. Both are there in children. Got this? Okay. Difference being alba has an atopy history in the family. So mother being asthmatic, child being asthmatic, eczema coming in the child, all that is an alba history. Indeterminate Hansen, remember atrophy? Atrophy is a very typical Hansen history. So in indeterminate Hansen also I have seen a few questions which says atrophy ho gaya. है ना? And endemic areas again coming into the picture. So can you see this? Clinical touch to what we are doing. Try to pick up them. I understand that we understand the questions are going to be long stemmed. But long stem does not mean information is long. Junk information is going to be a long thing. A lot of junk information might be there in the question just to lengthen the question. But the pickup words remain the same. Trust me on this. If you know to pick up the pickup words, you will not be spending too much time in even reading the whole question. If you know what to pick up in that entire paragraph kind of question. Got this? Got this? Okay. Now versicolor, I told you what? Multiple small. Can you see the same trend here? Can you see this? Multiple. Sorry, the pen is kind of doing some funny thing. Anyway, I'll just zoom in and show you. Can you see this? Multiple small. Remember that same trend, multiple small on the face is going to be pityriasis versicolor. So face 3 diseases, indeterminate Hansen, then pityriasis alba and pityriasis versicolor. Difference being what? Alba and indeterminate Hansen very close, but versicolor very different. Multiple small is how you pick up the entire disease process. Okay. Now, what if the question says acquired white में depigmented? I told you acquired white hypo. Now we are going to acquired white depigmented. Only two possibilities. Remember, only two possibilities: vitiligo and contact leukoderma. There's no third possibility for you. Acquired depigmented. Remember, congenital depigmented was what? Remember, congenital depigmented, only two options were there: albinism and piebaldism. We are saying acquired depigmented, only two options: vitiligo and contact. How do you differentiate between them? Very easy, very easy. Leukotrichia is not seen in contact leukoderma. It's usually a skin depigmentation in contact leukoderma, and vitiligo will have skin and usually hair also. Can you see in this image? Can you see the skin is depigmented, the hair is also depigmented? So it cannot be contact leukoderma, the first clue itself. Do you get that? Okay. Now, you can have segmental vitiligo, which is going to be a linear thing. Okay, it's going to be coming in a straight line. So vitiligo can also be very long and linear, because sometimes what happens is I've seen students ki if something is in a linear form, they say हाँ कुछ Contact leukoderma. No, even vitiligo can be linear. That's called segmental vitiligo. Got this? And how do you differentiate from contact leukoderma? Okay, see this. You have to know that contact leukoderma, if it's because of slippers, obviously it's going to be linear, correct? And can you see this kumkum with this center thing? So you have to in your mind say, oh, can it be something external causing this? Okay, so in the image before, if you see, there's nothing external which can go like this from the trunk to the limb, correct? And but this can be explained by something in your mind which says kumkum, which says slippers, which maybe says earrings, maybe a ring, okay, maybe a hair dye. So something like that you have to look at for contact leukoderma. So only two possibilities what we know, right? Now, once we know the pigmented diseases, face also has something which I've made a very big chart, and this is really going to be vital for you. I'll zoom it up as well. So when you say pigmented lesions, I said hypopigmented we have done, depigmented we have done. We also need to know colored lesions on the face. Quickly we're going to do this. Colored lesions on the face, any color on the face. Every question on colored lesion, just check one thing. Has it mentioned photosensitivity or has it not mentioned photosensitivity? Okay, if it says yes, there is photo, let me zoom in, go to the left side. Okay, if it says yes, there is photosensitivity, okay, plus, okay, there are only going to be three possibilities: rosacea, SLE, melasma. Rosacea, SLE, melasma, only three possibilities. I'm zooming in. Okay, how do you know rosacea? There's going to be a lot of flushing, redness, no comedones. Pick up these words: papillary inflammation, some nose rhinophyma. In SLE, constant fixed erythema, okay, no nose involvement, no rhinophyma, no papules, no flushing. One more is melasma, is also photosensitive, but this is going to be brown. This is going to be brown. This is going to be brown. Got this? And cheek and nose, very typical. Let me show you the images. Okay, can you see this? Very typical rosacea, a flush, a redness coming there, involving the nasolabial folds, coming and going, coming and going, coming and going, is rosacea. Okay, can you see the papular rosacea now? So after the flush, they get a papule in rosacea. Papule is never ever a feature of SLE. Remember this. It's always in SLE a flat lesion. Okay, okay, let me just, I hope I have the, yes, SLE. See the SLE rash? It's going to be a millar rash. Can you see it's a flat rash sparing the nasolabial folds? Got this? And there is no rhinophyma on the nose, no flushing, and that is typically a SLE. So three differentials. Okay, rosacea, SLE, and melasma. Okay, can you see melasma? Very typical brown, 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 brown. Usually not in males, but you can have a male image also. All three photosensitive diseases, right? Let's go back. If the question says photosensitivity is not there, absent photosensitivity, what are my choices? What are my choices? Remember this. Acne could be a possibility. Nevus of Ota could be a possibility. Port wine stain and infantile hemangioma. Four possibilities for a facial lesion without photosensitivity. So can you see it's consolidation? We have done all these topics in the teaching schedule, but I'm just putting it together. Acne, nevus, port wine, infantile hemangioma. Let's give you this. Let's give you this. Let's give you this. Okay. Now acne. Very typically what we call as polymorphic lesions. Polymorphic lesions. Okay, polymorphic lesions. Polymorphic matlab multiple morphology. So you'll have a comedone, a papule, a pustule, a nodule. Can you see the polymorphic? See the image. The yellow is the comedone and the red is the papule. Can you see multiple morphologies? So that's typically how an acne lesion obviously looks. Okay. Now there is something called as acneiform eruption. Acneiform eruption means drug-induced acne, and that typically has what we call as monomorphic lesion बच्चे. Monomorphic मतलब एक ही morphology है. Okay, sorry. I'll just give me a moment. I'll open that PPT again. Yeah, I was on this acneiform eruption. Okay, so acneiform eruption I said was drug induced acne, right? Have you got this? Now this drug-induced acne is monomorphic, means only papules. Remember this. Only papules on the, you can see it's on the chest, right? So if you have acne form, it's always going to be chest and the back, monomorphic papules. On the face, it's going to be polymorphic. So that's how you differentiate acne, the standard acne, from drug-induced acne, usually because of anti-TB therapy. Anti-TB therapy. Got this? Right? Okay. Can you see this monomorphic morphology of the rash and acneiform eruption, which is so different from the acne that we usually would see? Melasma we have seen. Nevus of aorta, all of us know, but just a quick revision. A blue lesion with a scleral pigmentation. We have done this so many times, so there's no confusion. Should not be a confusion in this, by the way. Nevus of aorta typically. Port wine stain is going to be a red rash. Remember, it's going to be a red rash. Usually unilateral, usually since birth, and usually may have some eye involvement suggestive of something called as Sturge-Weber syndrome, some eye involvement, some CNS involvement on the same side, a vascular swelling which is then going to be red. It's going to stay throughout life. So remember, it persists. So remember PNP, port wine stain persists, meaning that's why it's an adult, because it stays like that throughout life. Okay. I don't know if you know the USSR president at that time, Gorbachev, he had this, if you remember, a port wine stain right on his forehead. So these are people who actually have this, throughout really life. Okay. Now, infantile hemangioma, oma means a swelling. So remember, it's not flat. It's elevated. That's the first point. It's a tumor. Infantile, you should remember that this goes away. So that's why it's a baby's image. A red rash like this, usually on the face, but there's no treatment required. Remember, no treatment required because it goes away on its own. I'm going to give you a quick snippet on this. Okay, quick snippet on this. If the infantile hemangioma involves the eye, okay, these vital structures like the eye, then the drug of choice is a drug called as propranolol. That is only in case it affects vital structures like the eyes, or it's near the nose or near the mouth, or it's ulcerating, it's threatening to ulcerate, then you can give a beta blocker to arrest the growth. It's the drug of choice. But if it's not on a vital area, just leave it alone. Don't do anything about it. Okay. Okay. We have done a very extensive pigment discussion. Let's also do quickly a Hansen discussion. I can never leave Hansen. Hansen is one of those star topics which I really want you to know about. Okay. Got this? Right? So please focus on pigment, focus on Hansen. Okay, let's give you some pointer words for every Hansen. I made a chart like that. Let me just zoom in so they can see. I'm going to read quickly. So these are only the pointer words for the entire Hansen and each type of Hansen. TT, always remember the word single. वो अकेला रहता है ना? He's always a single fellow. So single lesion, single nerve, and well-defined borders. Single lesion, single nerve, well-defined is enough for you to pick up Hansen. Okay. And one thing I can write on this, it's going to be a lot of sensory loss and a lot of sweating loss. So extremely symptomatic. Okay. Now let's look at BT. Now see what I have put as a bold, satellite lesions and some few. So it's got some company. It's not a single lesion. It's got some company, but it's going to be satellite. That's what you need to know. The number of patches would increase. If you look at BB, typically BB is going to be a punched out lesion. Typically is going to be punched out. Swiss cheese, inverted saucer, very important, very important. Now multiple lesions and very importantly two borders. I'm going to show you the image. Inner border is well defined, outer border is ill defined. So remember double morphologies in BB. How do you remember double? BB, two letters, no? Duplicate, two, remember two, B and B, so two borders. Remember how remember this? Two borders, inner border different, outer border different, BB Hansen. Got this? BB Hansen. Now BL, remember multiple lesions, uncountable, almost symmetrical. These are words which if you really pick this up, nobody can fail Hansen's. This is a chart I have made myself, okay? And this is come only after almost 10-12 years of teaching dermatology at DAMS. Okay, and this is just kind of squeezing extra information into just very relevant information. And if you just by heart this chart, there's no one who by hearts this chart and does not get a Hansen question. Even if you don't understand the image, these words are enough for you to pick up the disease process. Okay, got this? Multiple, almost symmetrical lesions. Okay, this also has punched out inverted saw. So BBBL both have punched out lesions. Okay, let me give you LL. Now what I need you to know is multiple, but see the words diffuse infiltration. See the words now. Infiltration and nodules. Nodules are not there in any other Hansen. The moment nodules are written, mark it as LL blindly. Nodules are always only a part of LL. So in DT, it's everything is flat. Towards LL, everything becomes elevated because of infiltration. Okay. Now perfect symmetry. See the words on both sides of the midline. Glove and stocking anesthesia, and very importantly, bache, no hypopigmentation and sensation. Sensation are normal. Sensation are obviously normal. Okay. Okay, sensations are typically normal. I'll just wipe this off once. Give me a moment. I'll just wipe this off so that it becomes more clear, you know, as a chart for you, all of you to by heart. Okay, just one day before your exam, I want you to do this at least once. Okay, if you do this properly, you cannot fail Hanson's. Okay, please trust me on this. In one table, we have been able to, and you know what, you know this, right? I take about 2 hours to finish Hansen when I teach you in regular batch. This is 2 minutes and your Hansen is done. Okay, I cannot overemphasize the importance of this table, right? And this table I've not given you before. It's table I've specifically made and I've given it to you first time here, right? So please, and trophic ulcers, again, a few things I will read again. Some trophic ulcers, some earlobe infiltration. See all these words now. Glove and stocking anesthesia. Did I write glove and stocking in BL? No, I pushed it to LL. Okay, trophic ulcer pushed it to LL. Earlobe infiltration pushing it to LL, and this is why we need to understand this. Okay, somebody said, what is Swiss cheese? Beta, Swiss cheese is the other name for double border lesions. उसको हम Swiss cheese बोलते हैं. बीच में gap होता है. Right? Okay. Let me show you then images for correlation. Can you see TT? Remember the word atrophy I used for Hansen? TT has atrophy. Okay. Can you see single, like a bachelor, a single lesion, hypopigmentation, well-defined borders, sensory loss, one, everything is one. Remember TT as 1. Okay. Now Swiss, this is your satellite. Okay. So it's got some company, as you can realize, a yellow, a big lesion and a chota sa satellite. So it's got some company. Dost mil gaya usko, right? And that's a BT. A BT Hansen. BT is the commonest Hansen in India. How do you remember that? BT, you can remember that for Bharat. In Hindi, right? Bharat, BT. BT is the commonest Hansen that we have in India. Okay. Buddha ear is, yes, bache. Khyati, Buddha ear is a part of LL. Earlobe, anytime you have any questions that ear ka kuch hua hai, ear is always LL. Remember, ear is always LL. Okay? Now BT, can you see again? Saath mil gaya usko, right? A satellite, and typically you have 3 to 10 lesions. Shiva, yes. Swiss cheese at both BB and BL, bache, both. Okay. BT Hansen, double patches, hypopigmentation, again, flat lesion. Okay. Now look at BB, very important image. I expect BB to be the most important image in Hansen. Amongst all the images that I'm going to show you, I expect a BB Hansen image because examiners are fond of a BB image because it is a weirder image, not like a standard Hansen image, right? Now see, can you see outer margin, which is demonstrated by the yellow arrow, and the inner margin, double margin? Can you also see normal skin in the center? We call this punched out or Swiss cheese. हम लोग स्विस चीज नहीं खाते तो हमें इतना पता नहीं होता स्विस चीज कैसी होती है, but you know, you can remember those dosas, no, which have these fenestrations in the center, like gaps in the center, and you have that, you know, that thing on the edge. So that is, you know, the Indian version of the Swiss cheese, but the concept is center there's a gap. That's what it is, the Swiss cheese, right? And remember, it is also an annular morphology. So moment annular is there, you will confuse it with what? You will confuse this with tinea. And that is the intention of the examiner कि भाई इसको confuse करते हैं, ये BB Hansen mark करेगा कि tinea mark करेगा. So let me show you how to differentiate a BB Hansen which is annular versus a tinea which is annular. Let's give you this. Okay. Now Remember one thing, which is a scale. That is where the entire, remember I told you Hansen is never scaly. So BB Hansen में scale तो नहीं हो सकता. But can you see the scale here? A peripheral scale, and that is tinea. Remember, it is very, very itchy. Itching can never be a part of Hansen. Got this, everyone? Got this? Okay. Now one more annular lesion is something called as pityriasis rosea. Pityriasis rosea. Okay. A pityriasis rosea may, remember, there's always going to be this shape which it takes. Lesions will take this shape which is along the ribs. Remember this line, this name. Any image which shows something annular along the ribs on both the sides is always pityriasis rosea. Never confuse that with tinea. This is also going to be scaly. So scaling में दो है. Tinea is scaly, pityriasis rosea is scaly, BB Hansen is not scaly. Remember, everyone? Got this? Okay, just to show you the difference. Okay, just to show you the difference. Okay, just give me a moment. Yeah. Okay. Now can you see tinea? Again annular here. Okay. But look at the other side. Look at the other side. I've just kind of given an image. If I just zoom in, there's an annular lesion, and can you see the lesions then? Even though the lesion is not there here, but it will start coming like this along the ribs. And that's typically what is pityriasis rosea. This is typically only a truncal disease. It will not really come on any other part. So always remember, pityriasis rosea has a first lesion which is annular, and then rest of them are secondary lesions which are always going to be like a fir tree pattern, but both of them are going to be scaly lesions. Remember, these both of them are scaly. So see the left side and the right side, both annular, both scaly, both itchy, but difference is the secondary fir tree lesions and lesions along the rib. Okay. Remember also, somebody asked me granuloma annulare. Granuloma annulare is also going to be an annular lesion. That's why it's called annulare. There's no scaling. So that is why when there's no scaling, the DD is Hansen, obviously, right? The difference is there is normal sensation. So it's just an annular lesion, that's it. And if you do a biopsy, you'll find a granuloma, simple. So it's called granuloma annulare. Remember, it's a part of diabetes. And that's a question which may come. It's a diabetes patient, an uncontrolled diabetes patient who has granuloma annulare, no scaling, normal sensations, typically on the dorsum of the hand. See the site, dorsum of the hand. That's a site because it is sun induced, UV induced. So this is enough to diagnose granuloma annulare. Dorsum of the hand, annular lesion, no scale, and typically you can search an image on Google. Unfortunately, I don't have it here, sorry, because I didn't expect that question from you. So you can search it up, you'll find an image like that. Dorsum of the hand, annular lesion, diabetes, normal sensations, normal sweat, and no scale. Got this, bache? Okay. Madhu Parna, how to diagnose single herald patch? Okay. Single herald patch is not going to come for you in your exam, don't worry. Okay, I understand it's going to be confusing from tinea, but if you have a single herald patch here near the rib line, you can still suspect it to be pityriasis rosea. Got this? Okay. Now let's go to BL. Now BL uncountable, can you see uncountable? Multiple number of lesions, but can you see all of them are flat? Remember, they are not elevated, no nodules. Almost normal sensations. Okay. Differential, remember that? PKDL. I showed you that image earlier, and that past history of fever is how you differentiate. Got this? Okay. Now when you say LL, see what will come into the picture. You have these nodules. Can you see these nodules? On the earlobe infiltration kind of thing. Can you see the nodules here? Elevated, lateral madarosis, loss of outer bundle of eyebrows. None of this is a part of any other Hansen. Got this? Okay. Some students also are confusing how to diagnose in your MCQs type 1 versus type 2. Again, I made a special chart for this. Please hear me out on this. Type 1 is inflammation on, remember, existing lesions. Whatever is a leprosy lesion, just that existing leprosy lesion becomes red. Now type 2 is new and what? Nodules. So when you have any nodule in Hansen, nodules are either LL itself or type 2 lepra reaction. The only two possibility of nodules. And how do you differentiate LL nodule from a type 2 lepra reaction nodule? Type 2 is painful nodule and this is painless nodule. I hope you got this now. Very easy to differentiate. Painless nodules is LL. Painful nodules is type 2 lepra reaction. Everybody got this? Okay. No fever and fever. No fever versus fever. Neuritis may coexist. There's no neuritis in type 2. In type 2, you'll have a history in the question saying joint pains, some testicular inflammation, some jaundice, some red eyes, some kidney issue, lymph nodes. All this is type 2. So see the question. A patient comes with painful lesions on existing leprosy lesions. There's no fever. Patient also complains of pain at the elbow. That's a neuritis coming in. So that's a type 1 lepra reaction. See the type 2 question. Patient comes with painful nodules with fever. He also reports joint pains and red eyes. That is type 2 lepra reaction. So easy to differentiate. Usually type 1 is after MDT. Type 2 is also usually after MDT, but sometimes it can even come before MDT. Let me show you the images. See the comparison images. Type 1, देखो type 1. Can you see this is a single lesion? Type 1 usually happens towards the tuberculoid side. So TT is one lesion, no? So वही lesion लाल हो जाएगा. But there's no fever. See what I've written below. Tender edematous erythematous plaque on leprosy lesion itself. There's no new lesion. That's type 1 lepra reaction. Type 2 is going to be nodules, tender nodules. These are new lesions. Got this? That is how you differentiate type 1 versus type 2 lepra reaction. Got this? Type 2 versus type 1. Very important image difference. Type 1 is a flat plaque. Type 2 is an elevated nodule. Type 1 no fever. Type 2 fever. Type 1 neuritis. Type 2 orchitis, arthritis, systemic inflammation, uveitis, glomerulonephritis, lymphadenitis. See the difference? Type 1 towards the TT side, type 2 towards the LL side. And that's really how you just drill this into your head. And how to differentiate type 1 versus type 2 in the image. Okay? Very important also to differentiate erythema nodosum, which is a very close differential of type 2 lepra reaction, versus erythema induratum. Erythema nodosum, remember, is always a nodule on the shin, whereas induratum, which is a type of tuberculid, is a nodule on the calf. That's the central most difference between the two. Okay, erythema nodosum will not ulcerate, and this will ulcerate. So that's a very important. I'll read what is written below. Tender edematous nodule on the shin and no ulceration. This again on the calf. This time it is ulcerating. So one is tuberculosis, one is erythema nodosum. That is how you differentiate from erythema nodosum leprosum, which is type 2 lepra reaction. See the history now. Again, I'm going to tell you sample questions. A patient has painful nodules on the arms. See the image, see the question. On the arms. He has fever. He also has orchitis, arthritis. See, that's ENL history. ENL history. EN history is what? Painful nodules on the shin. Again with joint pain, but shin is going to be there, right? Erythema induratum, ulceration on the calf, right? So can you see the ENL, the image was on the upper extremity. So pick that up, upper extremity ENL. Lower extremity, two possibilities, erythema nodosum, erythema induratum. Nodosum front, induratum back. So simple now, simple now. Got this? This is how you differentiate this. समझ में आ रहा है? And the final topic, blister. Okay, again, a vital part. Okay, this time I made a 3 situation program to differentiate blistering diseases. So I'm going to give you situation A, situation B, and situation C, and you're going to be thrilled कि इतना simple कैसे हमने उसको कर लिया. बस that's it. Every blistering disease that you will encounter in your MCQs can be put into 3 categories. Situation A, situation B, situation C. Situation A, you will have a certain way of diagnosing. Situation B, a certain way of diagnosing. Situation 3. So every question, try to put into ABC first. And then it becomes so easy, so easy, so easy. So let's do that. Okay, everybody ready for this? Situation A, B, C. Khyati induratum in lepra reaction nahi bache. Erythema induratum is a type of tuberculid. Erythema induratum is the other name for nodular tuberculid. Okay, which is a tuberculosis thing. It has nothing to do with leprosy. Okay, everybody ready for this? Situation A, B, C. मजा आ रहा है? अच्छा लग रहा है? Got this? Everybody got this? You will have to see this video again. I am pushing in a lot of information into your head, and mind you, none of this is new information. All of this is the same information which I've done with you before, but see how when I do this in this way, you are now thinking कि अरे ये तो बहुत extra information है, extra कुछ नहीं है. But just try to do this before the exam. There is no way you will make a mistake from this. Okay, you're really going to be happy that you did this at the end. Okay, as A, B, C is what we are going to do. Now let's look at situation A. Situation A is going to be a question which says flaccid blisters, okay, raw skin and mucosal lesions. Okay, तीन चीज, remember, flaccid blisters, a question says a patient comes with flaccid blisters, या patient comes with raw areas, या patient has mucosal lesions. तीन चीजें, तीनों combine है. Flaccid blisters, raw areas, mucosal lesions. Now, if the question does not say blisters, then you will be confused, but question usually will say that. Okay, and then raw and mucus. इतना बस हो गया. So this is what you put into situation A. And then how do you then go ahead with situation A? Right, see, this is what I mean by raw areas. Can you see the raw areas? There's the image for what that image would be of a raw area. Raw area, raw area, raw area. Bas, simple. Okay, can you see the ulcers, mucosal involvement? Mucosal ulcer. Okay, see this? And typically this mucosal ulcer will have irregular margins. Irregular margin. It's not going to have a round margin. Round means aphthous. Remember, any round margin is called an aphthous ulcer in the mouth. But if the ulcer margin is irregular like what you see here, it's going to be a blistering disease. Simple. Aphthous, round margin, irregular margin, blister. Got this? Okay. So irregular margin. तो तीन हो गया, flaccid blistered, raw areas, mucosal. तीनों चीज दिखा दी. अब see what are my differentials? Not many differential. Very simple now. Very simple. One possibility is pemphigus vulgaris. बस remember this. ये तीन आया तो usually 99% time you will mark it as pemphigus vulgaris. खत्म. ज्यादा सोचना ही नहीं है. ठीक है? So see, raw areas on mucosa and skin, no targetoid lesions, no black necrotic skin. Simple. Raw areas all over the body, lot of mucosal involvement, as you can see in the image also, if you can appreciate. Can you see the raw areas in the mouth? Can you see the raw areas on the skin, on the right side, blisters which have ruptured to give you this raw areas, pemphigus vulgaris. Okay. Now just a schematic on this. Typical pemphigus vulgaris schematic, very beautiful schematic representation. Raw areas, some blisters, some raw areas, some blisters, and irregular ulcer. Remember the irregularity of ulcer in the mouth and the genitals in pemphigus vulgaris. Okay, got this? Okay. What is the differential? I told you two possibilities are there, no? 99% of time pemphigus vulgaris, 1% the possibility is toxic epidermal necrolysis. Got this? So 1% chance in that MCQ, this is TN. Got this? How do you differentiate TN from pemphigus vulgaris? Again, it's a new chart that I am making for you this time. First time I have not given you this chart, even the DVT. I'm going to give you right now. So this is going to be bleeding, and that's where the question comes. Bleeding, yeah, blood niklega. Okay, I'm going to show you this. Pemphigus vulgaris is only raw areas. Let me show you. Can you see the bleed? Everybody can notice the bleed here. Let me zoom. Can you see the bleed? That's enough. That's toxic epidermal. Okay, that's toxic epidermal, bleeding crust on the lip. Okay, one more way to differentiate. Targetoid lesions, no targetoid. Targetoid means something goal like this with two zones. Black necrotic skin. That's it. Nikolsky is positive in both. यहाँ पे there's no black necrotic skin. So just 1 minute of diagnosis. How? I'll just revise. How do you differentiate toxic epidermal from pemphigus vulgaris in your MCQ? Both will have flaccid situation here. Flaccid lesions, raw areas and mucosal involvement. Got this? TN में क्या होगा? Bleeding crusts, targetoid morphology and black skin. Bas, I'll show you this. Can you see now targetoid morphology? Can you see the black skin and two zones? Two zones means red on the edge and a bit black on the center. Targetoid lesions, targetoid. Can you see here again? Can you see black, black, black something in the center? You'll never find this in pemphigus vulgaris. Never find this in pemphigus vulgaris. Okay? When I say toxic epidermal, I also mean Stevens-Johnson syndrome because both of them are almost similar diseases, right? Okay. Now, can you see this black skin again, everyone? Can you see the raw areas? But can you see black skin? Everyone remember the black skin. That's how in the raw areas here. And Nikolsky positivity. So remember, I put that below in the lettering also. Black necrotic skin, Nikolsky positive. Okay, you will never find that in pemphigus. So situation A में दो ही था, pemphigus and TEN. तीसरा है ही नहीं. How simple is that now? Where is the complication in that? Right? Situation A हो गया. Okay, can you see again black necrotic skin peeling off? There's a word that is often used in questions on TN. Okay, sorry, the pen is giving me trouble. It's called sheet like separation. Can you see the sheet like chaddar ki tarah skin nikal rahi hai? So you'll never find these words in pemphigus vulgaris. Sheet like separation is toxic epidermal necrosis. Okay? Situation B, flaccid blisters or scaly lesions, no raw skin and no mucosal lesions. Simple. Okay, flaccid blisters or scaly lesions, no raw skin and no mucosal involvement. Got this? दो ही possibility है वापस. Only two possibilities. Staphylococcal scalded skin syndrome (SSSS) and pemphigus foliaceus. दो ही बचेंगे. Quickly you can do this now. Okay, difference कैसे करेंगे? See, can you see the scaling? Can you see there's no raw area? Can you see there's no mucosal involvement? How do you differentiate? Very easy. एक बच्चा है, एक adult है. Simple, simplest way. SSS is a disease of children. Okay? Can you see child? Can you see adult? Difference ही हो गया ना, खत्म. The diagnosis is done. Okay? One more very important. Staphylococcal. तो ये तो हो गया fever ना. This is fever. And there is no fever. What else do you need for diagnosis? Got this, everyone? Both will be Nikolsky positive. So that way you cannot differentiate. So fever versus no fever versus child versus adult. And you understand this is going to be DIF positive and this is DIF negative. I put that in the bottom part also. So you will have this video with you. You'll have the information. I'll just read that. Scales, mucosa is normal but child, and fever and DIF negative. So very, very easy to differentiate. Everybody? Okay? So Staphylococcal scalded syndrome versus pemphigus foliaceus, दो ही बचते हैं, right? So 2 in situation A, 2 in situation B, and then go to situation C. Okay? इसमें क्या आएगा? Tense blisters plus no mucosal involvement. So how simple is that? How easy it becomes now to solve a blister. Tense blister without mucosa. अब देखो इसमें 3 possibility हैं बच्चे. It will either be bullous pemphigoid, it will either be dermatitis herpetiformis, or it will be linear IgA disease. बस ये 3 ही होता है. Bullous pemphigoid, DH and LIGA. Got this? In bullous pemphigoid, remember it's going to be tense blisters, obviously, but remember the pointer word old people. बस एक ही pointer word याद रखना है. It's always a disease of elderly. And typically the blisters will come on red skin. Okay? On red skin. So I'll just write that. Pointer word. Elderly population. Blisters will come on red skin. This is going to be itching, is going to be plus, single plus. So elderly blisters come on red skin and single plus means thoda sa itching. Okay? So that is the image I'm giving you. Now, this is DH. Typically a DH image is going to be a scratched skin. Remember the blisters may not really be even visible. And remember the elbow area. Can you see the elbow site? Itching. So remember this. This में क्या हम note करेंगे? Any age. Okay? And itching is going to be plus. Remember this. And elbow. That's how you pick up. Enough for this to be picked up. Very, very itchy. with some kind of celiac disease inside, some gluten intolerance, and elbow lesion. Okay. LIGA is typically going to be blisters in a ring. So it's an annular blister, and that's enough for us to pick up an LIGA. Everybody got this? So 3 possibilities, and that is how we finish the entire blister in what, 5 minutes versus a blister which used to take 1 hour to do in the class. So situation A, situation B, situation C is enough. You cannot go wrong with this, and I can tell you this with a lot of heart and trust. Okay, master situation A, B, C, and you are done. Master that table in Hansen and you are done. Master the hypo and depigmentation and the color on the face, and then you're done with pigmentation as well. Right? So can you see the amount of volume of information which is instilled in those small tables and charts that we did for you? Okay. Now quickly, just in the last 2-3 minutes now, histopathology is also important in blisters. So I'm just going to give you some 3-4 histopathologies. Please hear me out on this. Okay. Pemphigus vulgaris. Can you see this now? 3 layers above, 1 layer below, row of tombstone. All of you know this, right? Pemphigus vulgaris. Remember to identify histopathologies. Okay. Remember to identify histopathologies. Okay. Now, Pemphigus foliaceus. Pemphigus foliaceus. Stratum corneum upar. Can you see the blister niche? But you know, how do you differentiate this? If you say that the bigger amount of skin is below the blister, okay, and the minor part of skin is above the blister, that means upar sirf stratum corneum hai, aur niche there are 3 layers then. So this becomes a pemphigus foliaceus blister. Versus if I go back here, can you see the bigger area is on the top and the small area is below the blister? So that means this smaller is below. So that means the below is stratum basal and above are 3 layers. So this is pemphigus vulgaris. Can you get this? Because in the exam you can't find out. You can't find out कि ऊपर कितने हैं नीचे कितने हैं, but see the thickness. अब the roof is thicker, then it's pemphigus vulgaris. If the floor is thicker, it's pemphigus foliaceus. How simple is that? Floor and roof, इतना याद रखना है. ठीक है? Now histopathology of bullous pemphigoid. You will find, and that's how you want to now look at a lot of skin here. But what I want you to know is eosinophils. If I can just zoom in on that, can you see eosinophils there? So that is your diagnostic point of bullous pemphigoid. Eosinophilic infiltrate under the epidermis. Under the epidermis. Okay. Now DH, histopathology of DH. Okay. Can you see this is a papilla? समझ गया बच्चा? मजा आ रहा है? अच्छा लग रहा है? Are you learning with joy? Are you still having that smile on your face कि यार कुछ आज अच्छा सुनने को मिला, कुछ अच्छा सीखने को मिला? So just stay in that happiness of learning something new and having some clarity. Clarity is life. Clarity is joy. Confusion is sadness, right? So let's not have confusion in the mind, right? So this is now a papillary tip. Papilla ke tip pe blister hai. And that's typically how we look at papillary tip blister and also papillary tip neutrophils. So sirf papilla pe hai, it's going to be dermatitis herpetiformis. Okay. One more histopathology. Again, I expect this to be a tough question if it comes. Histopathology of Hailey-Hailey disease. Remember a dilapidated brick wall appearance. Okay. Where you will find some cells sticking together in some way. Thoda sa, it's going to be attached in some way. Okay, thoda sa attachment to hai. It's not massive separation. There's going to be some gap and some brick, and a gap and a brick, and a gap and a brick. We call this dilapidated, bache. Dilapidated brick wall appearance, very typical histopathology, suprabasal blister of Hailey-Hailey disease. Okay. Now, this is again I expect this to be just a quick snapshot of how I want this DIF. I've just typed it for you. So just see this just for a quick moment. If I just zoom in, this is now fishnet. Can you see the fishnet? Just for quick revision. Fishnet. On the left side, what have I written? Fishnet, IgG and C3 in the epidermis. We know this is pemphigus. Okay, let's go down. Let's go down. Bullous pemphigoid, second one. Bullous pemphigoid, CP and EBA. Linear IgG and C3 along the dermoepidermal junction. Okay. Let's go down further. LIGA. linear IgA along the dermoepidermal junction. Okay? And DH, can you see if I just go here, can you see it's only a tip IgA, just at the papillary tip. So a snapshot of the 4 DIs which are important for you. Fishnet we know, linear IgG3 we know, linear IgA we know, and papillary IgA we know as well. And that is how we understand how to differentiate on DIF. Got this, everyone? Right? Everybody got this? With this, we have finished what we set out to do. Okay. What I want you to now understand is just give me 2-3 more minutes, and then we'll close this wonderful endeavor of DAMS to deliver a quality end to the entire schedule that you're having. The must know was basically designed for you to have a renewed perspective and, more importantly, momentum, okay, towards your preparation. Removing the confusion, trying to focus on what is important and removing the junk. That was the entire event. Today, what I did, why did I choose only these 3? That's my understanding on what is important. And if you master these 3 topics, you are through. Okay. Now, I would love you to tell me whether you found this session to be informative, to be productive for you, because I didn't give you anything new. Okay, we just played with what we already know. उसी को घुमाया हमने, but वो घुमाना जरूरी था. That churning reactivates your derma neurons. We call them derma neurons and synapses, derma synapses, right? So that's wonderful that we have. Okay, now I would just finish with something that I just at the core of my heart. What is going to be your biggest enemy till your exam? And I don't have any doubt about this. This will be your biggest enemy. Your biggest enemy is not कि pemphigus vulgaris आता है कि नहीं, कि TN समझ में आता है कि नहीं. Your biggest fear is going to be, biggest enemy is going to be fear. Fear of what? Fear of failing. Put your hand on the heart and say, do you have that fear right now inside you? You do. कि नहीं होगा तो क्या? What if ... And usually after that ... is negative, right? What if I don't make it? What if my friends make it? What if I don't get ahead in life? Okay. What if this doesn't go well? What if all my effort comes to zero? You always fear that things go wrong. What if you change that? What if things go very right? Is that not a wonderful way to say this? What if? Can you entertain that possibility that things can be right as well? What if God has a plan for you? What if somebody is there to have a blessing for you? What if something just comes at the end and pushes you across the finishing line? Is that not a wonderful thought to keep in your head? You know what that will do? That will remove fear. Fear is the only reason why you lose rank, by the way. Most of you might not even be studying properly right now because of that fear कि नहीं होगा मेरे से. The motivation dips. And most of you will ask, sir, motivated नहीं हो पा रहे, हमको बहुत डर लग रहा है, हम रात को सो नहीं पा रहे. क्यों? क्योंकि you have to counterbalance that with an argument which is so beautifully positive that will drive the fear away. Fear will come back, however, and you drive it away. Fear will come back, you drive it away. Every time you open the door for fear to come out of the door, but the fear will come back through the window. You push it out of the door, it comes out of the window. That's what I want you to do every day till your exam is over. That will shut off the fear of failing, fear of losing respect, fear of losing your dreams. If I tell you one thing to do from now till your exam, every day tell yourself, things are going to be wonderful. That's what you sleep with, that's what you wake with. And that is what gives you a very nice productive day. Stay with DAMS, stay with what we give you, stay within your dreams. Don't stay within your fears. Dreams are going to make you feel alive. Fear is going to make you feel constricted. Okay? Your life is going to be a roller coaster. Remember that. Till your exam, some days are going to be beautiful, some days are going to be bad. Beautiful and bad. Beautiful, this will keep on happening. Remember the power of discipline. Every day you will not feel motivated enough to study. कोई दिन ऐसा होगा आपको लगा नहीं पढ़ने का मन नहीं कर रहा. You think Rafael Nadal and Roger Federer feel perfect every day they wake up? They don't. Still they go to work because they are professionals. Try to be professional in your studies. Some days you feel lousy, you still work. Okay? And I have a final phrase for you to leave. Okay? And that is just show up. It's a very powerful phrase. Just show up. In the morning when you get up, just show up to the fight. Okay? Take your chest back. Take your shoulders back and your chest out and say, I'm showing up for the fight today. Let's see what the day brings me. I'm showing up. Okay? And that is how you win. Just show up to the journey, to the game, and that is how winning happens. Alright? Alright. Wonderful, bache. Now with this, I take your leave. I'm sorry I extended my time. Okay? Things are going to be wonderful. Just show up. Okay? And if you're down, if you feel down, another phrase, get back up. Get back up, get back up, get back up. Okay? Get back up. Right? Right. We're going to make it. Yes, wonderful thing that I introduced last time. I cannot wait for the rest of my life. That's a Celine Dion song. Listen to it. It'll really make you, make your hair stand on the end. You should think of your future like that. You should be expecting wonder out of your future. And you should be able to say this with all your heart, that you can't wait for the rest of your life. Your next 3 years are going to be the cream and the gem part of your living. Okay? Expect it. Be happy with what you're going to get into. Then don't get drained into the fear of what not and what I'm not going to achieve. Okay? Let's be excited about our futures, right? Chal, buckle up. Let's now finish this journey of ours. Thank you very much. Thank you very much. God bless. Take care. And all of you are very dear bachas to us. We just get so energized when we are around you. Somehow some of the inner adrenaline comes out when you are there. Thank you very much for all that you do for us. It just makes us do so much for you as well. Thank you very much.